All right, so we're going to go ahead and get started. And again, of course, we've got just a caveat there. Obviously, it's great to actually see all the questions in chat, and definitely great to see the engagement with the activity, and especially to still see, most of you just still sticking around through the second day. That's really good. So we can think about conditions and diagnoses in a couple of different ways, right? So on the one hand, we can think about them as comorbidities, right? And you've got some disease or condition, or if you could even get into thinking of social factors and other things as relating to or affecting some care or outcomes for the primary condition of interest, right? And so that's going to typically, it could render a person at higher risk. It could affect the types of services that are chosen, right? There are all kinds of things that we want to try to account for those for. And when we start thinking about using CMS data to identify some of those pieces as we're answering our questions, we want to think about, okay, why are we including that? Is it just to adjust for risk? Am I going to run a subsample analysis at some point? Am I thinking about interactions between conditions? So there are a lot of reasons why we might include comorbidities in our analysis. The other thing to think about is, how do we treat these variables methodologically, statistically? What do we do with them in our analysis? Why would we create an index or a score as opposed to just controlling for all the individual ones, right? There's a lot of, we want to think through some of those things, because it's easy to kind of just do what everybody else has done, but that can actually lead us away from the actual question that we want to ask and the estimand that we want to obtain. Right. So we're going to get through some of those things and think about the use of some of those measures. So obviously, we're typically thinking about using diagnosis codes, right? We're looking for diagnoses for conditions from the Medicare files. And we pull these conditions from lots of different places in the claims: inpatient, hospital outpatient, carrier file, etc. We have a lot of different choices on how we use these. We could, going back to strengths and weaknesses segment from yesterday, often we actually have the statistical power to just put in a bunch of indicators for conditions. So we could just put a bunch of extra variables in our analysis. Now, the exact interpretation you're going to get from that might be a little questionable, but that's a choice. We could select a standard set or number of conditions. So I may say, well, this standard set are the things that have been identified in my clinical area as the really key comorbidities that are common or especially complicating, etc. So we could do that. We could take every single possible diagnosis code that exists in the data and bucket them in some way, put them into categories or count them or some other way of doing that. We have ways of doing that. So in other words, accounting for every possible thing that we could see in the data, and then figuring out a way to kind of collate all that into something that we can fit into a statistical analysis. And lastly, we could think about weighting conditions, creating weights for the conditions, because of course, if we go and create flags for particular conditions, that's just a binary 0-1 indicator. But that would mean that every single condition gets a binary 0-1 indicator. And while some conditions will probably be more predictive or better confounders to account for than others, some of them are going to have more clinical weight than others, and that's not really represented by simple 0-1s. So in some cases, we have seen weighting approaches where you not inverse probability weights, but weights for conditions to show that some conditions are expected to have a greater impact on clinical care outcomes, etc. So I'm going to look at a couple of these, for example, and just walk you through. And just so you know, I actually, in my the clinical outcomes course that I teach, I actually walk through students through the original papers for these two, because a lot of times people use these, but they don't necessarily know a lot about them. So I'm just going to go through a couple. There's the Charlson Comorbidity Index, and then there is what is called the Elix-Hauser score. And I will tell you why I think that that's not appropriate, but we'll get there. So the Charlson Comorbidity Index, if you look at the original paper, Mary Charlson and her colleagues looked at a number of different conditions. I believe this was in hospitalizations in New York at the time, and identified 18 conditions abstracted from hospital charts to predict 1-year mortality. So, and if you realize, a lot of times when we're using Charlson nowadays, we're not necessarily predicting mortality, we're predicting all kinds of other things. And yet people use Charlson. Well, how? Well, there have been a number of different adaptations aimed at different sets of outcomes over time, but especially the adaptations in administrative data have come through in several different iterations. So Romano et al. has been commonly used. What is really common to see is you will see a Charlson dash and then the first author of the adaptation. So you might see Charlson dash Romano, Charlson dash Deo, those kinds of things. There are some software macros out there. We are listing one here. I would just always caution you to make sure that you know what you're doing when you're picking a software macro off the web. So this is a weighted index. That is, weights are applied to these specific conditions, and then those weights are added. So it's a sum, but not a sum of a count of conditions. It's a sum of the weights of conditions. And so we've got these here where the weights have been applied in a particular way, and we'll get to how that is, but you can see that, for instance, AIDS, metastatic solid tumor have a weight of 6, right? So if all a person had was metastatic solid tumor indicated in diagnosis codes in whatever adaptation you're using, then at least if we were using these weights, that person would have a Charlson score of 6. On the other hand, if a person had mild liver disease, ulcer disease, and connective tissue disease, all of them indicated in the diagnosis codes, they would have a score of 3. And you can argue whether that's appropriate or not, but this is the approach that was used. So how did we take, or how do we take this? How do we actually create these weights? Well, these weights actually represent the relative risk from a model, from a regression model. These represent the relative risk in Charlson original paper et al. They represent the relative risk of 1-year mortality. And so the relative risk of 6 was translated into a weight of 6, and then they just add them. So there's nothing magical about it. Could you choose to do it another way? Yeah. But that's how they approached it. And I want you to remember that relative weight in just a second. We're going to come back. That has implications later on. Anne Elixhauser and her colleagues looked at a larger set of conditions, 30 conditions developed to predict length of stay, hospital charges, and in-hospital death. So again, you can see that both of these originally were looking at hospital populations, which, again, having just looked at the carrier file, you can kind of think about, well, actually, there's a lot that goes on in Medicare that doesn't happen in the hospital, right? So that original article, what's interesting about these sets of conditions is that they just identified which conditions are predictive. They are not weights. It's a list. And actually, in the original article, if you read it, and this is why I have my students read it, is because they actually suggested not aggregating these into some kind of a count or list or in some kind of a count or index. They just said this is a list of conditions. And so not necessarily creating an index or score, but these are conditions that you'd want to account for. So it's interesting now that we now usually say something like an Elixhauser score, even though Elixhauser herself kind of recommended possibly not doing that. There are a number of different software macros available. You can go to HCUP as a really good resource. I would probably trust that one. I know that there have been some macro updates in the past. So again, just always pay attention to what's going on in code if you're going to be pulling a macro from the web. Now, Gagne et al. Combined Charlson and Elixhauser. So sometimes I have seen people whose health systems have a calculated Charlson-Elixhauser score, Charlson-Elixhauser score. They're probably using the approach that Gagne et al. Took in that. So if you've ever seen that in your health system, some kind of a calculated score like that in an electronic health record, they're probably using the Gagne approach. It is better at predicting mortality than either one alone. And again, there's a software available there. Again, always caution, just know what you're getting, buyer beware. So we've got this difference here where what Gagne et al. Did is they took conditions that were both in Charlson-Romano and ones that aren't in Charlson-Romano that are in Elix-Hauser. And then some from the Charlson-Romano that were not in Elix-Hauser, made sure that those stayed in. And then using these, they took the Charlson approach. So if you look at the far right of this slide, you don't have to pay attention to much else. You can see the far right of this slide, there are weights now for the combined score. So again, similarly, you would create these weights based on a statistical model with a relative risk, and then you get a set of weights and you add them, right? So it's a summed score of weights. So what this does is a count would actually say, sorry, I won't move on yet. A count would say, if I'm just counting things, everything is weighted 1. This allows things to have different weights based on some outcome you're predicting. And anybody could do this. Anybody can take this approach for their own particular outcomes. So again, this isn't, there's nothing magical about this. It's actually fairly mechanical. So if you look at C statistics, in terms of mortality, the combined score actually does a better job than either one alone, which is kind of the takeaway of this slide. All right, now, so here's from the MedPAR. We took from the MedPAR the Gagne combined comorbidity score. Maybe in the chat, if you could kind of put in the chat, if you could kind of put something that you think might seem a little strange about this graph. This is a comorbidity score. Yeah, less than 0. What happened, right? Very good. So think back to the mechanical way in which the Charlson score was obtained. A relative risk from a model. Well, that means in this model, some things were actually below, right? So some things are actually on the negative side. So somehow having a condition, having it present, is associated with lower risk. Here is where data generating mechanisms and the ways that people access care and all other sources of bias come in. When you follow this approach, there are going to be certain things, and I brought this up yesterday, there are certain things that are going to happen, and you just have to understand that there are consequences for that. And so one thing that happens is when you look at the Medicare population, as I said, hypertension is almost ubiquitous, right? Or at least extremely high rates compared to the general population. Well, in this case, hypertension is one of the conditions that's indicated for a lower risk. This is why you never trust data. So why would hypertension, maybe in the chat, why would hypertension be protective? Why would it look like it's protective, I should say? Because it's clearly not. Just some thoughts. Think about ways that it could be biased. Good. Okay. Yeah. Good. Okay. So we're seeing this. So the idea is that it represents, yes, and there's also probably some collinearity and other reasons, but one good example would be that if somebody has hypertension, that means that they are getting a good workup and their diagnoses are ending up in the data. If they are not, flip that. A person in the Medicare population is not diagnosed with hypertension. It is very possible that that person is not having good access to care. We've done looks at people who we got a really good sample and really good sample and denominator design for people who had diabetes. And it's actually pretty striking, the number of people who, say, in a previous year had been diagnosed with diabetes and did not have a single visit for the entirety of a calendar year. There are people who lack access to care in Medicare. And so this is a case where at least one reason is that insurance does not equal access, as we've all learned. The other condition gets a little bit more surprising. Maybe I can go back. Does anybody see the other condition? Yeah, HIV or AIDS. So here's an interesting thought. What if we have an incredibly selected population of people who have HIV/AIDS in the MedPAR file or in the Medicare program? In other words, we're talking about people who have a condition that, at least for a very long time, was a really, really serious diagnosis, and yet they are alive to be in our data. Right? So we have survivorship bias. We also probably have people who are getting really good access to care. And of course, there are some statistical things that could be going on. So here's why we can end up with things that are unintended. We don't want these things to be scored below 0, right? We wouldn't say that they are actually in reality protective in some sense against comorbidity and its effects, but they happened because of the approach. And so regardless of what the exact reasons are and whether it's access or whether it's survivorship bias, whether it's statistics, the point is it happened because of the approach, not because of reality. And that means that the kinds of permutations that we get into when we start trying to create something to actually and you'll see it, you can think about it when we get into the Sammy segment on creating an analytic file. You need to kind of think about, okay, what I'm really doing is I'm pulling diagnosis codes from those fields you just looked at in the exercise. That's where I'm pulling them from. And then I have to figure out what to do with them, because the code by itself, right, is an alphanumeric string in ICD-10. Well, I can't really put that in a model. So I have to create a variable from that. And the way that I do that, and then the way that I combine those variables into my actual analytic file and in my model, is going to have implications. And so while we might say, well, I'd rather use a weighting approach because I don't like everything being weighted 1, that itself, how we do it, will have implications for our measures and in turn for our models. All right, so if we're going to identify beneficiaries with an important chronic disease, whether I'm creating the denominator for my study, so it might be a disease-based cohort, or whether I am trying to identify a comorbidity, how do I do that, right? We have to think, we have to make a lot of choices, because again, this is a process. We are making this happen. It doesn't exist on its own in reality. What exists are what you've seen in the activities. Right? You've seen how they look kind of in the file layout. So how do we pull that information and make it look like something that we think we can use in an actual model? And so in doing that, we have a lot of choices actually that we have to make. Which diagnosis codes do I use? What procedures? So CPT or other HCPCS codes, which ones should I use? Should I use them? Should I only stick with diagnoses? Which administrative data file should I use? Should I just use the carrier because I'm just interested in clinical care? But what if they had a hospitalization and that was something that was really important? So thinking about which file, do I go all the way to skilled nursing? What do I use? Which positions in the diagnoses? As we've talked about, if we're talking about principal or primary diagnoses, a lot of times those might be in positions that are more toward the front end, positions 1 and 2, for instance, of that large count of diagnosis codes that could exist. Do I use all of the fields? Maybe could that create a specificity problem if I used all the fields instead of just the first 2 or something? So thinking about what position on the claim, right? In that list of diagnosis codes, do I use all of them? Do I use some? And lastly, another consideration is how do we determine whether I'm doing a good job? Because if you only have the Medicare data and you are not doing a validation study, right? How can I determine success with only those data? Or have we seen some validation work to kind of show us what does a good job and what doesn't? All right, so in talking about validation, I'm just going to throw this up here from Epidemiology 101 or something like that, or Biostats 101, in terms of true, false positives, false negatives, true negatives, etc., and positive and negative predictive value, and sensitivity and specificity. Just as a reminder, because we'll be looking at some validation. All right, so how do we identify beneficiaries with diabetes? Well, we have a lot of different diagnosis codes, and we could update these for ICD-10, but you get the point. There's not one code, right? As I said yesterday, there's not one code. And so if I really want to make sure that I'm capturing everybody, I probably want to account for other possible codes. You could think about the same thing with lots of different disorders and conditions. You could think about depressive disorders, for instance, several different codes, right? Position of diagnosis codes. Okay, so if I look, I have my code list. I put together a code list. I've looked at my ICD-9 or ICD-10 manual, and I've identified all the codes that I want to. Okay, do I take just the first condition? Do I take the first two anywhere? I don't know. Procedure codes, do I include them? There are a lot of procedure codes for treatment of diabetes, so do I include those? Which administrative files am I pulling this code list from? So I've started with my code list, but I still have all these other decisions I've got to make. So luckily, there has been some work on this. Hebert et al. Is one example. You can definitely find, I know I've found validation studies for, I think, AMI and a couple of others. I think stroke maybe. So there have been some validation studies that have looked at administrative data and then validated them against what they considered to be a gold standard. Typically like a chart type review, but it depends on the study. So other people have followed up, and what has kind of coalesced is this idea of, and this is going to be hit on again and again and again. If you look at the top, the title here is you want one claim. So at least one claim, because that's another thing. Do I just want one? Well, what if somebody was tested for diabetes but didn't have it? Because the diagnosis of diabetes could definitely still be there, right? So do I just take one? Do I need at least two, right? So what is coalesced is this idea of if it is from the inpatient or skilled nursing files, I'll take one. Because if somebody's diagnosed with something in a hospital, at least theoretically, the idea is that, okay, we can probably trust that diagnosis. But if you're in the outpatient space or you're in that monster of the carrier file, people get a lot of care that is accounted for in those files. And so that means that, gosh, somebody could have had a test for a condition, right? Or maybe there was diagnostic uncertainty about a condition. And therefore, appearing just one time in those kinds of files, we might actually want to have a little bit, protection against a specificity problem there. So in the outpatient and carrier file, it could be two. And so it's an either or triggering or switch for that indicator. That has really coalesced as pretty much the most supported idea. Hebert et al. Is one example. There's been some other validation work that usually kind of finds something similar. Okay. And so for a lot of the condition codes that you'll see in the master beneficiary summary file chronic conditions segments, they follow this algorithmic approach. So just some support for this is, this is from Hebert et al. And again, other people have done this too, has been looking at a number of different algorithms, which are just sets of rules that we apply to the data. Right, that's all it is. It might sound like technical, but it's just a bunch of rules. So if you want to look at the far left, you don't have to get into the numbers too much, but just to show the kind of approach that's been taken is, on the one hand, they have at the very top, the farthest left is, not very top, at the top of the actual content of the table, is the number and type of diabetes claim, and you've got one or more claims with diabetes, so at least one. And then further down, about 2/3 of the way down, you'll see two or more claims. So that's testing this idea of, do we just need one? Do we just get two? What does the sensitivity and specificity look like if we just do that? And then those are applied to each of the different types of files. Now, these are going to have slightly different names because, as you've seen, the names of files change over time. This is from the 90s, so you're going to see slightly different names for some of these. Short stay hospital, so inpatient hospital, skilled nursing, home health, hospital outpatient, and then physician/supplier, which would be the carrier file. And then you've got similar things down below where you've got hospital outpatient and physician supplier tested for two claims, so that they can kind of make that comparison again, because of the issue of maybe these things aren't, they may be overly sensitive or under specific, right? If we do that. And so in looking across all these then, in the different files, within each file, they're also testing the variation on where in the claim we find that. So the third level of kind of bulleting in this test on the left side is it the first listed diagnosis? So is the diagnosis the first diagnosis in that list, or is it anywhere on the claim? And they're doing that for each of the files. Okay. So this is the kind of comparison that they've done. Now, each of these is just testing one on its own. And so that's why we're getting these super high specificities, because we're not looking at combinations necessarily. We're looking at each file, each position. Okay, so that's not the approach that we take, though. We use an OR approach. So the OR approach is they added, they took those rules and added them into essentially making an OR statement and saying, okay, now it could be one short stay, one one inpatient, one skilled nursing, or one home health, or two or more hospital outpatient or physician supplier, that is carrier. So that's kind of the approach that has become the norm. And it's when you start combining the files and actually looking across them using these algorithms, you actually get pretty good, much improved sensitivity, and specificity still remains pretty high in most cases. If you do look at the positive predictive values, there are some things where things do drop down a little bit, but otherwise, we're actually, we greatly increase the sensitivity and still keep a lot of that specificity there by using these kind of combined approaches. And so you can experience some improvement with, trying to play around with the different claims. Most of the time, people are trying to use all the files to capture things. And so that's why we've got this one inpatient skilled nursing or home health, or two hospital outpatient or carrier claims in a given 1 to 2 year period. And that's another thing that they're testing here is, okay, do we just need 1 year of data or two? Now, the one thing I would note about this is that these algorithms are being tested on the Medicare population. So if you took this and looked at a population that may have less complete data or more disenrollment, like the Medicaid population, particularly like the Medicaid expansion population, you might want to rethink some of the algorithmic rules, which just kind of is just an illustration of the fact that we need to be thoughtful about these and not necessarily just automatically pull things off the shelf and use them. So anyway, this is some of the support for this kind of approach of the one inpatient skilled nursing or home health, or two hospital outpatient or carrier claims. That typically is the logic that is used in most of the algorithms that we're going to look at in just a second, that are used in the chronic conditions and other chronic conditions segments of the master beneficiary summary file. So in other words, these algorithms are already applied for you in those file segments. Okay, so but we'll get to those in a second. I'll show you how these translate into what Chronic Conditions Warehouse actually communicates in there about their algorithms. So this is just an illustration of this is why this particular approach is supported. And again, this is identifying some of those chronic conditions. How you use them is then a choice. Do you use the whole set? Well, we'll get there in a second. So there's been some additional looks at people doing these, and again, just most of the time you get pretty good support for the algorithm that I've been listing, that set of rules and files and so on. So the chronic condition data warehouse, to take that logic then, the logic of those algorithmic rules that have been applied when you're extracting information from the claims files to make these comorbidities or these chronic conditions, to identify them. And I would say we are making something. So it's important just not to reify these things. These are things that we have done to the data to make something, which is a variable. And there's always going to be a degree of measurement error. And we just want to keep that in mind. So you can use these indicators from the chronic conditions warehouse. And actually that link, the ccwdata.org, they have, it's like a nice list that actually shows their full algorithms. And I think I've got a copy of it or a part of a copy of one on a future slide here. So keep in mind that these exist in a couple of different segments in the master beneficiary summary file. As you've probably noticed, when you hear the word file in Medicare, a lot of times it's actually multiple segments. So like a base claim, revenue center claim, revenue center, in this case, the master beneficiary summary file, right? You've got the kinds of demographic information, other things, and enrollment information, but then you've also got these chronic condition segments. The nice thing is that like a lot of the other structure of the master beneficiary summary file, the layout of these chronic conditions and other chronic condition segments are actually nice. They're pretty clean compared to the rest of, to the actual claims data, even though these are actually extracted from the claims data. So you could go through the process yourself and do this. This is just a very convenient, and I would say, having gone through the cost process, a pretty low cost thing to identify a lot of the conditions that you might be interested in. The main thing is knowing what's in the algorithm and whether you think they're missing anything or whether you think it's right. So these are in those segments of the master beneficiary summary file. We have yearly indicators going back for most to 1999, which is where most of our data go back to right now. We've got standard definitions, we've got criteria for the reference periods and which codes are used and so on. They're actually available, again, at that link, ccwdata.org. You can check them out yourself. And then you've got the date. They also have an ever date, which is the date when the standard definition was first met. So there were 21 original chronic conditions. This is within my time working with Medicare data. There was a list of 21 conditions, including a lot of different. You'll note that most of these are pretty. Physical focused. So if a person like me who's interested in mental and behavioral health, this list on its own would have been pretty, disappointing. Depression in this case was largely major depressive disorder, but I think one version of it I saw actually included the depressive phase of bipolar disorder. So you could get some people kind of being marked as having depression when actually there was a diagnosis code in there that actually indicated the depressive phase of bipolar disorder. So you could say, well, that's actually not even that useful. And so there was this original list. And then there were 6 additional ones added to this. And you can kind of tell these are some things like hypertension and asthma and things like that. BPH that are, fairly common. And some people might be interested in them, but they weren't in the original set. So they were added. So that's the chronic conditions segment. The first chronic conditions segment. Separately, and this one, then there's they have just changed this version a little bit to have 30 conditions. So now where you've got cancer, Parkinson's disease, pneumonia, and some other things. And so some other things have been added to that original set of conditions. So it's like 3 new categories. And one thing to remember is that these are categories, they're condition categories, because they, if you say depression, that's a big wide thing. If you say diabetes, that's a big wide thing, right? Other condition definitions, and this is more of a caveat slide. This is why I forgot that this one was in here. It's more of a caveat slide, is that some of these definitions have changed. And so you need to make sure you know which version of the conditions segment, the chronic condition segment, you are getting, because it's not just added conditions. Some of the definitions have changed. We'll look at the definitions in a second, but for instance, AFib is now AFib and flutter, and there will be some additional or changed diagnosis codes and things like that, so that the newer 30 conditions file is not just 3 new categories, but actually some of the categories, definitions, and algorithms have slightly changed. And so if you were tracking something over time or other things, you just want to be aware of what version you're using for what year, et cetera. So just keep that in mind. Make sure you're looking at a consistent set of segments if you're trying to track trends or things over time, that kind of thing. Let's see. Yeah, examples of algorithm changes are added or deleted codes, changing look-back periods, so how much data are you using, and the number of diagnosis codes searched. So yeah, that's available from 2017 onward. So just a really important caveat, know what you're using. All right, now this other segment that I've been saying, other chronic conditions, it's other chronic, and I think the full name is potentially disabling conditions or something like that. And this is really exciting for people who were looking for things other than just kind of the more typical physical conditions that you would think of. Again, some of these and some of the original condition categories, you might say, well, because we've used some as examples, so obesity would be an example. You might actually still want to be careful. Just because these are created for you doesn't mean that what we've told you about being thoughtful about whether something is likely to be on a claim goes away. These are still pulled from the same exact data that we have been providing those caveats about. And so always think about, okay, oh, great, there's a code for obesity. Well, remember the cautions that we've told you about certain conditions and whether things are likely to be on claims, because these are pulled from the claims. So just because there's a code for something, or a code for a category of something, just keep in mind those kinds of cautions that we've laid out for you. It doesn't mean it's wrong, doesn't mean it's bad, but keep those in mind. So, but a lot of really cool things from a research standpoint, not cool things necessarily for people to have, all the way from a number of different, substance use disorders. They have now split up and added a number of different common categories of mental health conditions. Depression is now joined by, or depressive disorders is now joined by anxiety disorders, category for bipolar disorder, those kinds of things. And then you've got things like cerebral palsy and, in some cases, sensory issues and other things. So there are a lot of things here that I think a lot of researchers were really interested in. And this has happened within I've been using it for a little while, but it's happened within the time that I've been using it, definitely within the 2000s, and really after 2014 or so. So this is it's a good addition, I think. But again, just be cautious of where these come from. So where do they come from? That was a really nice segue. Where these come from, this is when I say you can go to ccwdata.org and look at the algorithms they're using, this is how they list them. This isn't all of them. This is just a clip from the very first kind of page for the chronic conditions segment. But if you look at asthma, which is the first one on the list here, remember, going back to those validation studies, they looked at all kinds of variations, and this is kind of what's been arrived at as kind of the common approach. So the reference period is typically 1 year. You sometimes will see 2. And remember that in the newer chronic conditions version, the 30 category version, that those reference periods might have changed compared to the earlier version. Some of the codes that are listed might have changed and so on. So keep that in mind as we're looking at this. But so asthma has 1 year of observation. You've got diagnosis codes listed for ICD-9, CPT-4, or other HCPCS codes. Now you'll note that in this case, all of these are just diagnosis codes. So there aren't any procedure codes listed here. And so that's any diagnosis on the claim. That tells you the position. Remember, that was something that was also tested. So it's not just the first or second. If asthma shows up anywhere on the claim, it triggers this algorithm if it happens in the places where they're looking, and to the number of times that they're looking. You've got the same kind of list for ICD-10 codes. Again, any diagnosis on the claim. And then on the far left side, you will see the number of claims that you have to see and the type of claims or the files that they're coming from. And you'll note that that CCW is using 1 inpatient, skilled nursing, or home health, or 2 hospital outpatient or carrier. So it's the exact algorithm we've been talking about. And so they're applying probably the most general algorithm you can apply for asthma in this case. But if you look at AFib, for instance, there's a little bit more specificity here, just in terms of what's being approached, in that it's a much more limited set. So in ICD-9, they're only using one diagnosis code. And then in ICD-10, they've got like 3, but they're all from that 148 set, or I-48 set. So and also they're applying that only the first or second diagnosis on the claim. So if it appears in position 3 through 25, it would not trigger this algorithm. Then over on the right, you'll see at least 1 inpatient or 2 hospital outpatient or carrier. So they are not including skilled nursing or home health in this case. Okay. And you can see that, again, there are variations when you get to BPH. There are exclusions. If they have a qualifying claims, also have an ICD-10 diagnosis of D29.1, then exclude those kinds of things. So you'll see small variations like that, but you'll note that generally speaking, these algorithms all look very, very similar to each other. And remember that an algorithm is just a set of circumstances or rules that have to happen in order for that switch to flip from 0 to 1. Now, we can get into all kinds of other ways. And I'm going to say this later, but I'll say it now just so that we can echo it. Keep in mind that every single one of these approaches, as well as the Charlson, Elixhauser, and the chronic conditions data warehouse chronic conditions categories, all of them are pulling diagnosis codes, typically diagnosis codes, sometimes procedure codes, are pulling codes from the claims. They're pulling codes from the same claims. There's no outside information other than, for instance, the weights used in the Charlson or something. There's no other special information that these are pulling from. So all of these are drawing water from the same well. That being said, there are a number of different things. So HCUP through ARC has its own approach to classifying conditions. And if you go back to when I first started talking about these, this approach is much more like grabbing everything that's on the claims and just throwing it into buckets. So there's not as much of an algorithm here. It's just kind of taking all the water that's raining down and sticking buckets under it. And each bucket's a different color. And that's how they get to this classifications approach. So the clinical classification software can be single level or multi-level. The single level is the most rolled up. The multi-level has more granularity at higher levels. So as you get toward the multi-level approach, you can get more specific in the clinical classifications. One thing to keep in mind is that this is from HCUP, which runs, the nationwide inpatient sample and the KID and some of those files, which are largely hospitalization files. So they're really trying to capture everything. So you'll see things that only happen in a hospitalization, but you'll see all kinds of other things. And a lot of it is with the CCS at the highest level, it's kind of like almost like a body systems bucketing approach. So it's kind of a little different than the way that we typically kind of count conditions and things like that. It also has a chronic condition indicator, the CCI, and that flags if a condition is considered chronic. And so if you use the CCI in combination with the CCS, you can get kind of like a count or a bucketing of chronic conditions. And that's kind of how those two can be worked together. The nice thing is, of course, it's at ARC's website for HCUP, and it's been used a bunch of times. So that's another approach. There's another one by Adams Dudley et al. for verifiable, expensive, and predictive conditions, or the VEP. And it's a list of, as might be indicated, 100 conditions that are verifiable, expensive, predictive, that is verifiable and chronic and expected to contribute significantly to total population costs. So this includes all kinds of things, various cancers, depression that's not in remission. So there are some codes of depression and remission that are excluded, anorexia, eating disorder, lots of different kinds of codes, and things that really are not included in things like the Charlson or the Elix-Hauser, but could still have a big impact on somebody's treatment and costs and utilization. So that's another approach. And you can, some of these have code, have code macros or have software macros ready to go. Some of you definitely have to hard code in yourself. Okay, so if you kind of make a comparison across a lot of different approaches, you'll see that really these end up having really different shapes. So they are drawing water from the same well, but they're pouring it into very differently shaped glasses. So the Charlson, you got those 18 conditions, but they're weighted as an index and summed. Elix-Hauser is a list of 30. Most people add them. They're not weighted, so it's just a count. It's a count of specific conditions, not all possible conditions. Gagne et al., of course, is that combination that we looked at that had the negative ones and so on. CCW flags, right? We had those 27, which is now 30, and then another 33 in the other chronic condition, other chronic and potentially disabling conditions. You've heard about hierarchical condition categories, so HCCs. 70 categories. I think there's been some changes. I know in 2014, there's probably been a couple of other changes since then too. I know that when we've worked with agencies that are really trying to pay attention to utilization and costs, a lot of the administrators of those programs have asked us to include HCCs as a key covariate because they're, for them, very administratively important. And that's kind of how they target to and things like that. And so we thought, okay, that's a reasonable reason to put something in a model. There's obviously the 100 conditions in the VEP, which again is typically you're going to get like a count, but it's a count of those conditions. But you'll note though that of course the potential numbers of conditions are going to vary a lot if you're counting things. Right? You've got the clinical classification software, which I mentioned is both single and multi-level. So single level, there are 285 diagnosis and 231 procedure-based categories. The multi-level breaks down across 4 different levels of specificity. It gets really down into much more weedy, but also in some ways more useful. And I think I'll show a comparison of what these actually look like maybe on the next slide. DRGs, being inpatient specific. Now, DRGs are, they've gone through several iterations. So even this 467 is not, I don't think, right anymore. There's like a new version every couple of years, or at least there was historically. But these are inpatient specific. So you'll get categories like newborn, right? And we talked about some of the other ways that the DRGs are created. Sometimes it's almost more like a procedure category, so surgery, for instance, rather than a condition per se. And then just note, I'm just listing one proprietary one that I've used in a project. I'm not promoting anything. If I were to promote something, I would promote something that the U of M created and not Johns Hopkins. But this is the ACG system is interesting. It's expanded diagnosis clusters, about 27 of those. But those are kind of filtered down from 267 expanded diagnosis groups. So depending on how you use these and what level you're using them at, it's kind of like the clinical classification software in the sense that you've got kind of different levels of granularity. And so you get 28 or so aggregated diagnostic groups, and then you get that branching algorithm again. So you start applying kind of the way that DRGs do with age and sex and some other things to get 93 total ACGs in that adjusted clinical groups in that system. So just a lot of different variations in the range that you could get, the conditions that are included, whether you include everything, whether you include only certain lists, all of these things, right? And not all of these come with ready-made algorithms the way that, for instance, the chronic conditions data warehouse categories do. So those list all kinds of choices that have been made in the algorithm. A lot of these are just kind of lists. And so if you were going to apply them, you would have to ask the same questions yourself. Anywhere on the claim, first or second position only, 1 year of data, 2 years of data, all those kinds of things. So you'd still have to be asking a lot of these things. And let's see. So yeah, this is the example comparison I was going to give. So again, this is just based on some things that usually have been more of my interest historically. So you can kind of look at, you've got the hierarchical condition categories. One category, and again, this depends on the version that you're using, but one category included HCC 52 included. You can get a score, by the way, of HCC 2. That's one thing I should note. You can get an HCC score, or you can look at the specific category as well. So HCC 52 is major depressive disorder and bipolar disorder plus delusional disorders. There's no kind of dysthymia or other depressive codes in there. Another one is schizophrenic and schizoaffective disorders. It's all kind of packed in together. There's no hierarchical condition category for anxiety disorders, or at least there was not at the time that I pulled this one. The CCW, other chronic and potentially disabling conditions, which is where, again, you're going to find most of those mental health disorders. You have separate categories for depressive disorders, which does include dysthymia, that kind of lower level, kind of ongoing depression rather than the more intense phases. Prolonged depressive adjustment reaction. So even some of those kinds of things. So it's a pretty big category. Bipolar disorders are separate in that case, as opposed to the HCC approach. Anxiety disorders are separate, which includes things like panic disorders, generalized anxiety disorder. And then schizophrenia, there are actually schizophrenia and other psychotic disorders is a kind of a separate category. So there's like kind of the specific schizophrenia, and then there's the broader category one, two separate ones. Then lastly, you can look at the clinical classification software as another comparison. And honestly, at the single, remember, it can be single level or multi-level. At the single level, it's a little more similar to the HCCs, much more rolled up and bucketed. Whereas the multi-level, it gets a little closer to the CCW in terms of having a lot more variation in what you're seeing. And then this is just another example. This is actually from a Medicaid study that I did, and it's just to kind of show you that depending on how you look at something, using different tools, you could get really different answers. This was from a sample of like 35 adults in the Medicaid expansion population, so very different from the Medicare. But you could imagine the kind of variation you can get depending on which tool you're using, right? If you look over a population. So the kind of takeaways here: consider the purpose that things were created for originally, and the purpose that you have in mind when you're looking for, adjustment or identifying your population or whatever you're doing. Just remember why things were created and why you want to use them and whether those two align, right? And also remember the source. So you could think about, okay, are we just doing risk adjustment? We don't care. We don't need to, we don't really need to look at those things. It's just risk adjustment. We're just throwing everything in that we can. Versus, do you have some specific approach that you want to take because you've got a theoretical kind of driven way of building your model, and you actually have a really specific thing you want to do with it. Right? You can repurpose things. Right, so you might take something that was mainly just designed. So if you think about the HCC score, that exists administratively, but you could use it as we have. You just need to be thoughtful about, okay, why are we using this? Does it suit our purpose? Another thing to think about is, do you need to interpret these things? So if you're going to be including something, are you worried about being able to interpret that? Or again, is it just for adjustment and you're not worried about it, actually interpreting that? If you are thinking about interpreting it, the other thing to think about is make sure that you've got all the important confounders for that variable. Are you worried about its relationship to an index diagnosis versus just any count? So there's a paper by Pete and Kerr that looks at comorbidity and diagnoses as being kind of in different theoretical buckets or ways that they affect care. And so there are things that they called related to the primary condition, in their etiology or their treatment, things like diabetes and hypertension possibly. So things that kind of typically go together, that come from some of the same types of things, and that you're kind of used to treating together. Then there are things that are unrelated, like diabetes and depression. They complicate each other in a particular way because they're not really alike, but they're in each other's way. And then they talked about ones that were, I think, dominant. I forget the word exactly, but it was conditions that basically were became the kind of primary diagnosis and principal diagnosis, and the main thing that you focus on all the time that is of most concern. And an example would be, for instance, cancer. Cancer care can kind of become a person's whole care, and it may even crowd out care for some other conditions. Or sometimes you'll get some clinics that will actually provide, say, primary care services to specific clinical populations, so that they can kind of keep everything coordinated. Right? So maybe that's the approach that you want to take. Are they validated on one outcome in the study that you looked at, but you're using them for another outcome? If so, think about whether you're confident in doing that. Right? A practical concern is that the chronic condition data warehouse chronic condition categories do exist in the master beneficiary summary file already. The work is done. And so if you're okay with it, but then you're thinking about something different, just ask why you're thinking about something different. The work's already done there. Lastly, remember source. As I said, these are all pulling water from the same well. Typically, ICD diagnosis codes, but they're all pulling them. You would be pulling all of these from the claims. They map to each other to varying degrees, but they are all coming from the same place. And so just keep in mind that, again, if you're kind of trying to make big comparisons about them, remember they are kind of all getting at the same underlying information. Right, questions? Let's see. For the variable names, what I would say is go to the data documentation for the master beneficiary summary file at resdac.org. You'll get all that information there. Are these apples and oranges? Some are about survival, but CCS are about identifying conditions. You could say that, but they are still all pulling from the same information and trying to represent it. I would say that Charlson and Elixhauser have both been used in several studies that I've seen that were not solely about survival. And so again, it's just that's why I'm just suggesting caution or thought before we just kind of use a variable that we know. Maybe there's a better one out there. And some of these are not actually about identifying conditions per se. They're really about adjusting risk. And that's, again, it shows that there are different reasons for why these things exist, right? HCCs were not created for researchers, right? Let's see. Well, it's important. So newborn and Medicare data, it's what I would say is remember that when I said newborn, that is for the clinical classification software, which is from the HCUP project at ARC. And so that's actually a random selection of hospital stays for everybody. So it's not limited to the Medicare. That was just an example that they are inpatient specific or inpatient focused, I should say. Let's see. I'm not sure about an algorithm for sickle cell. I would look at the data documentation for probably the other chronic and potentially disabling conditions. If not, another thing to think about is you could use the logic from those algorithms to make one for sickle cell disease. I don't know that I've seen one, but I would check there. And if not, again, you could kind of think about the same logic at least, if the logic makes sense to you. Let's see what else. Oh, good. There is one. Okay. Thanks. I didn't see that answer. All right. Anything else? I think I'm holding everybody up for lunch.
There was one question about what you might recommend for overall illness burden Do you have any
Oh, overall,
recommendations for that?
you asked, that's the wrong question to ask right before lunch. Yeah, I guess what I would say is, we've tried to be really thoughtful and creative when we have on projects that I've worked on. And if you're thinking about overall illness burden, what I would suggest as a start is look at, let's see, boy, there could be a couple of different things. Now that there are actually, there are actually measures of illness burden out there. So you could see if there's been any study that's been done linking particular conditions with different levels of illness burden on those items, on those kinds of scales. Yep, yeah, work on frailty could be. But I think it depends on, it's also going to depend on the kind of population you're looking at. So like I spend a lot of my time on the Medicaid population, and especially with childless adults, the expansion population. And so in that population, they statistically look older than they are, because there are high levels of homelessness and a lot of risk, social risk, and other things that are going on. But B, we're also worried about like all kinds of social things and trying to figure out how we pull from those. So it also depends on, are you thinking about an older Medicaid population? Are you thinking about people who are living fairly young in the community? Are you thinking about disabled? I would say that we can definitely say that there are going to be conditions not only that have high illness burden, but in a lot of my work, we've also focused on treatment burden. So what are those conditions that take up a lot of your time and effort and attention and those kinds of things? So I'm sorry, that's not really a good answer, but I guess the thing I would say is I would have to have a clinical population use case in mind to really, dig into some thoughts on that one.